Okay, in this final video on pituitary gland pathology, we're going to look at posterior pituitary disorders. I'm going to say a little bit about kind of the two major ones, diabetes insipidus and SIADH. Then we'll talk about hyponatremia. It's going to be important for you to know how to work that up in the clinic because hyponatremia could be related to SIADH, could be related to a lot of other things as well. And then we'll look at the details of the two major disorders there. I'm not going to talk about growth hormone or oxytocin problems because we really don't talk much about those in the conventional sense of endocrinology. We can say, though, more functionally low oxytocin levels might be related to, like we talked about, all those anti-stress effects and the pair bonding effects and so forth, which would be important to consider, especially when we work with more mental health conditions. Okay, in terms of posterior pituitary disorders, again, we're going to focus on ADH, and our two main disorders will be SIADH, syndrome of inappropriate antidiuretic hormone, and that's where we get a pituitary or an extrapituitary source of ADH, increased ADH, and that can be most commonly idiopathic, often transient, but it can happen with CNS tumors, infection, trauma. We can have ectopic tumors in the lung, GI tract, genital urinary tract, lymphomas that can secrete ADH. Pulmonary diseases, infections, asthma, cystic fibrosis can be associated with SIADH. There can be inherited genetic reasons for it. And then different medications, again, SSRIs, tricyclics, anticonvulsants like carbamazepine, oxytocin itself. Remember that has ADH-like properties. And then fluoroquinolones, morphine, valproic acid. So with excess ADH, we're going to see decreased urination, increased urine osmolality, we're going to see increased extracellular fluid, and that's going to result in hypoosmolality in the plasma, and hyponatremia is the big problem here, so low sodium levels. And because of that decreased plasma osmolality, we're going to essentially see water moving from the plasma into the cells. And so there will be intracellular volume expansion, and that's going to be a real problem in closed spaces like the brain. If neurons swell, that can lead to central nervous system problems that are very severe. So I'll go through that here in just a minute with hyponatremia, and that can even be fatal in some cases. So note in this case that the hyponatremia actually results from an excess of the water being retained, not from a deficiency of sodium. This is very important. So if you see hyponatremia on your CMP, so low sodium levels, and I'll talk about the ranges here shortly, we need to work that up and say, okay, what's the cause of this? Just giving extra salt is not always the solution. In fact, it will not be in the case of SIADH. The treatment actually for SIADH primarily is water retention, so you don't let the patient drink. That's one condition we don't want to encourage more fluids. So the treatment for that, again, is going to be water restriction. Going to try to identify, reverse the causes, maybe give diuretics to push off some of that water, and then we might need to address the cerebral edema. That's going to be more emergency procedures, and I'll talk about what to do in those cases. And then rarely we might use those Vaptan diuretics, which block the V2 receptors for ADH in the kidneys, thereby decreasing the effective ADH on the kidneys. All right, so that's going to be SIADH. The other would be diabetes insipidus, and that's a lack of ADH. And there's several forms. The most common is central, and that's where we get true deficiency of ADH from the posterior pituitary. It's also called neurogenic, not nephrogenic, but neurogenic DI, so central or neurogenic DI. Nephrogenic DI, NDI, would be from a kidney or nephron dysfunction where the kidneys become insensitive. Those ADH receptors just are not sensitive in the kidneys for ADH. So that results, you can have usually high ADH in those cases, but you're at the end stage not getting the effects of ADH. Third type of diabetes insipidus would be dipsogenic, and that's just from an excess intake of fluids. So one of the major symptoms of diabetes insipidus is constant diuresis, frequent urination. Again, this is why it's called diabetes. Diabetes mellitus, the classic diabetes that we think about, people often have polyuria, frequent urination, polydipsia, increased thirst. They also get polyphagia in type 2 diabetes. or a type 1 diabetes, diabetes mellitus. But polyuria, polydipsia indicates diabetes. The reason it's called insipidus is that when physicians used to taste the urine, it would not taste sweet in the case of diabetes insipidus, but it tastes sweet in the case of diabetes mellitus. Mellitus means honey. So diabetes insipidus, there's no problem with glucose regulation here, but you're having symptoms that are similar to a diabetes mellitus, and polyuria is one of the main ones. So one of the reasons a person can have lots of polyuria is they're just drinking a lot of fluids. And that can happen very severely in cases when a person has a stroke to the hypothalamic thirst mechanisms, or in mental illness. That can result in dipsogenic DI. A fourth type of diabetes insipidus occurs during pregnancy in the postpartum period. And this has to do with the fact that the placenta actually produces an enzyme called vasopressinase, which breaks down ADH. And this can actually is more associated with cases of acute fatty liver or preeclampsia, but this can induce a gestational DI. Typically, though, that resolves fairly quickly in the postpartum period. But in general, the lack of ADH is going to result in increased urination with decreased urine osmolality, increased thirst, and dehydration, which can be severe. And the treatment here will be to try to remove a cause if possible, to maintain adequate hydration. So that's very important here. So make sure patient keeps drinking enough water. And then maybe to use a synthetic ADH analog like desmopressin. Okay, so that's our two major posterior pituitary pathologies. Before I jump into SIADH in more detail, I need to say a little bit about hyponatremia, which is a fairly common thing we see in the clinic, and it's important to know, when do I need to be concerned about this? So by definition, the plasma sodium is usually between 135 and 145 milliequivalents per liter. And again, a CMP, complete metabolic panel, will include sodium as part of the electrolytes. And hyponatremia is when we're under 135 milliequivalents per liter. So in mild hyponatremia, we're 131 to 135. Usually we're not too concerned about that, but we might start looking at why that's the case. Moderate would be 120 to 130. Severe would be under 120, and very severe, which can be life-threatening or even fatal, would be less than 115. Again, when we have hyponatremia, that's generally associated with a lowered plasma osmolality. And as a result, water is going to shift from the plasma into the cells. And this is going to result in cell swelling. And if this happens in a closed space like in the skull, this is going to result in severe cerebral edema. And that can cause what's called hyponatremic encephalopathy. And again, that can put a person into a coma or can be fatal. Acute hyponatremia develops very quickly, in under 24 hours. And this is the one we're most concerned about. That can cause very acute cerebral edema. The plasma sodium drops well below 125, and we start to see nausea, vomiting, and headache. And when it gets really below 120, we might start to see seizures, coma, and respiratory arrest. And there's a 50% mortality with this acute hyponatremia. But most patients will present, especially in primary care practices, they might present, and this might be more typical of an elderly patient, with chronic hyponatremia. And that's going to develop over 48 hours. And we might see things like lethargy, confusion, muscle cramps, neurological impairment. With mild hyponatremia, there might be increased falls, maybe subtle personality changes, altered posture and gait, maybe reduced attention. Something people might chalk up to dementia, but actually it's related to the low sodium. There can be an increased osteoporosis risk also. So what happens with the low sodium is calcium is mobilized from the bone to actually try to stabilize some of the osmolality, and that can result in osteoporosis. And this can carry about a 10% mortality risk. But again, this is developing very slowly, usually over weeks or days. And it's amazing how well the neurons can actually adjust. The problem is if you correct this too rapidly with, let's say, IV sodium, this can cause a severe problem where now the fluid is going to move out of the neurons. But the adjustments that the neurons made to that state of osmolality are not going to be quickly reversible. And so this can result in failure of the neurons and so forth. and we'll talk about what can happen. There's a very dangerous condition that can happen from overcorrecting the sodium too aggressively. So again, the cell swelling is least tolerated in the skull, and the more rapid the symptoms develop, and the more rapidly the hyponatremia develops, the more severe the condition. Okay, so a couple other little things here. Aldosterone usually normally causes sodium retention, is decreased when there's in fluid retention, when there's too much volume in the plasma. So more sodium is going to be lost also in the urine. So you're going to have dilution of the sodium, but also lose more sodium through the urine. So not a good state as hyponatremia continues to develop. So how do we work up hyponatremia in the clinic? How do we know what's the cause of hyponatremia? Is it due just to low sodium intake, which is actually pretty rare, or is it due to some other endocrine issue here? So we want to do several things. One is to gather complete history and physical exam. So I'm going to do like a neurological assessment, everything else. I'm going to collect labs, specifically plasma sodium. So again, the CMP includes the sodium, but we're going to want to rerun that as a separate test. Plasma osmolality, urine osmolality, and urine sodium. And these four will allow us to figure out what the real cause is of the hyponatremia. So the first thing is to determine a person's tonicity status. Are they hypertonic, isotonic, or hypotonic? So hypertonic hyponatremia over here in the tonicity status is when the plasma osmolality is high. So you get over 295 milliosmoles per kilogram. And you usually have a false reading here due to increased glucose or mannitol. So we're going to have low sodium with high plasma osmolality, and that's because of usually hyperglycemia, or if someone happened to be infused with mannitol, which is not going to be common, but usually from hyperglycemia. So a person with severe diabetes might actually have low sodium on the lab measurement, and that's really an artifact because of the high glucose. So those cases, we just treat the glucose. Isotonic hyponatremia, we call that pseudohyponatremia, is when your plasma osmolality is normal, but we have really high triglycerides and high proteins. So hyperproteinemia and hypertriglyceridemia can cause a false sodium reading, false low sodium reading. So that's isotonic hyponatremia. You got to treat the triglycerides of the high proteins. The true hyponatremia is hypotonic, and that's where you get a low plasma osmolality, and this is the most common cause of hyponatremia. So that's the first thing to determine is tonicity status. Next, if you figured out it's hypotonic hyponatremia, you got to figure out the volume status of the patient. Are they hypervolemic, euvolemic, or hypovolemic? I'll just say here before we move on, again, that dietary sodium deficiency is only rarely a cause of hyponatremia. So let's look through the different volume statuses here. So I'm going to use a couple of abbreviations. TBW is total body water, TBNA is total body sodium, and ECF is the extracellular fluid. So let's look at the two outliers here. So hypervolemic. Now this patient's going to be edematous. So that's going to be pretty easy to spot. They're going to have swollen ankles, feet, maybe swelling anasarca generally in the body, in the face, and so forth. They're going to have a total increase of total body water, and they might have a total increase of sodium, but because the water is higher in proportion to sodium, they're going to get hyponatremia. And the cause here is generally from heart failure, kidney disease like nephrotic syndrome, or renal failure, and liver cirrhosis. And we can further differentiate that by checking the urine sodium. So urine sodium that's low, it's going to be CHF, kidney, nephrotic syndrome, or liver. A high urine sodium will be renal failure. The treatment here will be essentially to treat the underlying condition. So we're going to do fluid restriction, maybe diuretics, and so forth. So I'm not going to talk too much about that one. That's going to be pretty obvious in your heart failure patients and renal and liver failure patients. Let's go to the other end, hypovolemic. These patients are dehydrated. So you might see skin tenting or signs of dehydration. So here we're going to have a total low body water, but also probably a low total body sodium. And this can have several causes. The most common would be either a kidney cause, so we get what's called renal salt wasting, and that could be from different nephropathies, but also diuretic use, even ACE inhibitors, mineralocorticoid deficiency, or what's called cerebral sodium wasting, all of these would cause an increased sodium excretion through the urine, and that can cause hyponatremia. So that's going to be pretty easy to spot with the medications they're taking, or on your CMP, indications of renal dysfunction. If you have a urine sodium that's less, so a low urine sodium, here we usually suspect extrarenal salt loss. So that's from dehydration, diarrhea, vomiting. This is when we usually think about replacing sodium with. Again, that's only a very small fraction of hyponatremic cases. The treatment here will be sodium replacement, and then maybe even giving IV saline 0.9%. Now, we have to be careful, and I'll talk about this in the next slide. Generally, I would not recommend any of you to do sodium replacement intravenously in your practice. This is where you want to really, if it's severe enough, where a person's having neurological symptoms, refer them to the ED. They probably have to be hospitalized so they can slowly infuse that saline. Otherwise, you risk something called osmotic demyelination syndrome. So if they've developed chronic hyponatremia over time, if you rapidly correct their plasma sodium, it can cause the neurons, the nerve pathways, the axons actually in the pons of the brainstem to demyelinate. And this will cause a massive loss of all your motor output from the brain. So a person becomes paralyzed basically from this, and it's not reversible. So this is where we don't want to just rapidly reinfuse sodium in those cases. So I'll talk about that in the next slide. But that would be the hypovolemic. But you have a large portion of patients who are hyponatremic. If we go back, they're hypotonic. So they have true hyponatremia, but they're euvolemic. There's no edema, no signs of dehydration. And what we have here is a total increased body water to a slight degree, but not to the point of edema. And we have normal sodium. So the sodium gets diluted out. So you don't want to replace sodium here. You have to actually correct the water problem. So this can have several causes. If the urine sodium is elevated, here is usually from loss through the kidneys, but also water retention, and the main cause here is Siadh. But hypothyroidism can also cause this. So can adrenal insufficiency. Notice that Siadh is independent of hypothyroidism and adrenal insufficiency. So you got to rule those out first, and then we might arrive at Siadh as a diagnosis. Post-operative pain or post-operative states, and then different drugs like thiazides again and ACE inhibitors can cause this. If you have a low sodium, so less than 20, but we're euvolemic, hyponatremic, that can be due to psychogenic polydipsia. We talked about that, where you overdrink, usually from a mental health disorder. Something called beer podomania, where a person drinks very large amounts of beer very quickly. Beer, curiously, is actually very poor in electrolytes. So you get lots of water, but you dilute out your sodium. And so you can actually get a hyponatremic state. That's pretty obvious to spot through the history, I think. And then severe, very high, like marathon runners, endurance exercise, could get euvolemic hyponatremia. The treatment here would be fluid restriction. So they get less than a liter in 24 hours, try to correct the underlying cause, and then maybe use those Vaptan Diuretics, which block the effects of ADH in the kidneys if they're having Siadh. You wouldn't use those for the other reasons here. All right, so it sounds complicated, but this is what you want to go through in your thinking in the clinic whenever you see someone with hyponatremia. You want to first see if it's mild, moderate, severe, and then you want to figure out what might be driving it. Okay, now that we know a little bit about the general causes of hyponatremia, let's focus in on Siadh. This is persistently high ADH secretion, independent of the serum osmolality, so there's no connection between the serum osmolality and ADH secretion. Patient's going to urinate very infrequently in proportion to their fluid intake. They're drinking a lot, and it's like, wow, I'm hardly urinating at all. They're going to have low serum osmolality, generally manifesting as hyponatremia again, and they're going to have, so their sodium is going to be under 135 milliequivalents per liter, and the hyponatremia is from excess water, not from low sodium. And they're going to have a high urine osmolality. Urine's going to be very concentrated. And so they're going to have continued excretion of the sodium, but they're going to be holding on to the water so the urine gets more sodium per water. Okay, and then they're going to have normal cardiac, renal, hepatic, pituitary, thyroid, and adrenal function. So again, we got to look through all those first to then arrive at the diagnosis of SIADH. And the hyponatremia in SIADH will correct with fluid restriction, and that's part of a diagnosis as well. All right, so that's the general features of SIADH. How does it present clinically? It really depends on the rate of development of the hyponatremia. So again, we want to classify the hyponatremia as mild, moderate, severe, or very severe. Usually with severe and very severe, you're just referring that patient right off to the ED, especially if they're showing, neurological signs and symptoms. And generally, if it progresses very slowly, they might have very little signs. And in an elderly patient, you might just notice things like confusion, again, increased falls, forgetfulness, things like that. But with acute, you're going to see more signs suggestive of things like when the sodium levels go below 125, you can see anorexia, nausea, real general malaise. And then as they decrease further, we might see headaches, muscle cramps, irritability, drowsiness, confusion, weakness, seizures, even coma. And then we're going to see essentially the brain cells, the neurons are swelling within a closed space, and that's going to increase the intracranial pressure. And so see maybe some papilledema with that too. So we want to look for all the potential causes kind of in our assessment: chronic pain, any recent CNS disorders, head injuries, pulmonary tumors, which might be secreting ADH, and then what medications are they taking, and then what's their fluid intake in general. And then how chronic has this been going? Is this less than 24 hours, or is it going on for weeks or months or years? So our causes of SIADH will be, again, CNS, like head trauma, tumors, meningitis, pulmonary disease like sarcoid, COPD, pneumonia, lung cancer, ectopic production. This will be part of the paraneoplastic syndromes and small cell lung cancer. A lot of drugs can cause SIADH, and that's important to know. So antipsychotics, you might see a person, they have hyponatremia, and it might be from SIADH from their medication. Narcotic analgesics, the opioids, barbiturates, the different anti-epileptic drugs, TCAs and SSRIs. Usually it's not as common with SSRIs or TCAs, but it's something to think about. And then again, have they had surgery recently? Are they in a lot of pain, prolonged exercise, severe nausea, or SIADH could be, in a lot of cases, just idiopathic. We don't know why it starts, but you want to do your due diligence to work through the list first. So working up SIADH is similar to the workup here for hyponatremia. First thing we want to look for we want to check the osmolality. That's going to be a blood test. See if they're have high glucose, high proteins, or high triglycerides, which might be confounding the test. But if they have true hyponatremia, we want to check their volume status. Are they hyper or hypovolemic? Again, SIADH is going to be euvolemic. And we want to look for any of the neurological signs: confusion, disorientation, delirium, the muscle weakness, myoclonus, tremor, asterixis, hyporeflexia, ataxia, dysarthria, even breathing issues like Cheyne-Stokes respiration, pathological reflexes, generalized seizures, or coma. Again, this is going to be all like, okay, send them right on to the ED if any of these are presenting. We want to check the sodium levels, of course, and then we can look also at the potassium, chloride, and bicarbonate levels. If they're hypokalemic with metabolic acidosis, that might be from diuretic therapy or vomiting. That could be causing their hyponatremia. If they're hyperkalemic with metabolic acidosis, then we might consider adrenal insufficiency or volume depletion due to acute kidney injury, which may be causing the hyponatremia. BUN will usually be on the low side because of volume expansion. Uric acid also can be low, although these both lack sensitivity for diagnosis. Blood glucose, we want to check that to make sure they're not hyperglycemic. And again, we might see reduced anion gap in SIADH. We want to check their serum plasma osmolality. Again, that should be under 280 to be hypoosmolar. And then we're going to check the urine osmolality, the urine sodium concentration as an additional test here. Thyroid, you should see a normal TSH, and maybe even checking cortisol if you suspect that would confirm the there's adequate adrenal function. ADH we don't directly measure usually because of a slow turnaround time on that, so we have to assess it through these other means. We might look at a chest x-ray if you suspect a pulmonary mass or lung cancer, or again a head CT MRI to see if there's any problem with, for example, increased intracranial pressure with narrowing of the ventricles, or if we're looking for tumors in the pituitary or hypothalamus. So treatment of SIADH really, in the rapidity, how rapid you correct the hyponatremia depends on a lot of factors. The degree of hyponatremia, whether the patient has any neurological symptoms, and whether if it's acute or chronic. Generally less than 24 hours is the acuity. Some sources say less than 48 hours, so you'll see both those in different resources. Currently, there's European guidelines that are used for the treatment of SIADH, and they recommend primarily to treat the underlying cause if you can. The first line treatment would be fluid restriction, so between 500 and 1500 milliliters a day, generally less than a liter per day. Second line treatment would be to increase solute intake, and that would be either urea or to give a loop diuretic like furosemide low dose with sodium chloride tablets, 2 to 3 grams TID. So again, this is second line. We really want to reduce the fluids first beyond just getting sodium levels up. Now, lithium has a blunting effect on ADH receptors. We'll look at that with diabetes insipidus here shortly. It has been used historically to block the effects of ADH on the kidneys, but the European guidelines suggest we should not use that. There's also demeclocycline, which is an antibiotic, which also has effects of blunting the ADH receptors. And then there are the Vaptan Diuretics I talked about, the vasopressin receptor antagonists. These are not currently recommended, but they're used maybe in limited circumstances in very severe patients, more in hospital settings and so forth. Emergent care, again, you're not going to be doing this in your practices, but you're going to refer to the emergency department, and this is going to be correction in severe neurological symptoms with hypertonic saline. But we have to really be careful about infusing that very slowly, no more than 10 milliequivalents per liter in 24 hours. The patients have to be monitored in the ICU because of the risk of central pontine myelinosis. And this can destroy again neurons in the pons, leading to motor tract outflow problems, but also dysarthria, dysphagia, diplopia, etc. All right, so that's a lot I know on SIADH, but again, hyponatremia is fairly common in a primary care setting, and we need to understand when do we have to be concerned about this and how do we sort of evaluate the cause. And finally, I want to say a bit about diabetes insipidus. This would be elimination of a large amount of dilute urine and increased thirst due to decreased antidiuretic hormone secretion. So we have decreased ADH. In this case, the urine is going to be hypotonic and tasteless, insipid again. The incidence is pretty rare, about 3 per 100,000 patients. The symptoms are similar to untreated diabetes, except again, the urine doesn't contain glucose. It doesn't taste sweet. Not that we're tasting the urine anymore. But the polyuria is the big one, and we're probably going to see signs of dehydration with that. But we need to make sure we rule out diabetes and kidney disease in those cases. And then polydipsia, increased thirst, often for cold or ice water, and often in excess of 10 liters per day. So people are just constantly pounding the water. So patients who come in and say, I drink, all this water, we have to be cleared and ask, are they doing that because they think they're just detoxing or hydrating, or are they just constantly feeling dehydrated and they need to drink that? So with all that water, we're going to dilute out, potassium and so forth, have frequent urination. Again, a lot of conditions can cause polydipsia, including the psychogenic polydipsia. So we have to look at those possibilities as well. So here we're going to get low urine osmolality because we're constantly urinating, diluting out the sodium and other things in the urine. And the plasma osmolality is generally going to be, can be high, but it can also be low. So and it can be normal. So it can vary back and forth. Generally here we can often see a condition where because you're urinating frequently, it pulls out a lot of water and the relative amount of sodium goes up. So you're actually going to get maybe a little bit of hypernatremia. It's not always there, but hypernatremia is a possibility. So ADH levels, again, slow turnaround time, but here, if this has been chronic, we probably want to get that test. We're going to see a decreased ADH in central DI, but normal in the nephrogenic DI. We're going to see, we're going to check for plasma glucose, electrolytes, so see what's going on there. We're going to look for potential hypernatremia if that dehydration really continues and develops. We're going to look for a low specific gravity, indicating a dilute urine in the urinalysis. And then we're going to check the urine osmolality and electrolyte levels, which will typically be low as well. Might need to do a head MRI, brain pituitary MRI to rule out a pituitary or hypovolemic lesion. And there are specialized tests that can be done for diabetes insipidus. It's called the water deprivation test. Again, this would be a referral usually to do this if you suspected this. Patient has no water intake for 2 to 3 hours, and then you have hourly measurements of urine volume, osmolality, and the plasma sodium concentration and osmolality. So we're going to check all those. And then in those with diabetes insipidus, they'll continue to urinate dilute urine despite the fluid restriction. So that would be a classic finding there. There's also a desmopressin stimulation test. Remember, desmopressin is synthetic ADH, has a longer half-life than natural ADH, and the patient ingests a normal amount of fluid. You give the desmopressin, and that should actually increase the urine osmolality in the central DI. But in nephrogenic DI, again, there's a blockage of those receptors in the kidneys. You're not going to see a correction. So desmopressin stimulation test can help differentiate central from nephrogenic DI. So going through our different types of DI again, central or neurogenic DI, low ADH secretion from pituitary tumors, could be autoimmune, post-surgery, encephalopathy, could be idiopathic, different drugs, or head trauma. We're going to find low ADH, going to find a low urine-specific gravity, a often normal or slightly elevated serum osmolality. Serum, again, serum plasma, we use those terms interchangeably in these cases. Hyperosmotic volume contraction. And then the water deprivation test will be a greater than 50% increase in urine osmolality only after administration of the desmopressin. Treatment's going to be with hydration and then maybe intranasal desmopressin and carbamazepine, which is an anti-epileptic drug, anticonvulsant. This tends to increase ADH secretion. So one of the side effects of carbamazepine could be SIADH, unfortunately. Nephrogenic DI, NDI, the collecting ducts become insensitive to ADH. That can be either primary, they could be hereditary causes like ADH receptor mutations, or more commonly secondary, and the big cause is lithium. So high lithium, like for bipolar depression, could induce nephrogenic DI. Could also be from kidney or nephron dysfunction, sickle cell anemia, so forth. So here we have normal, usually ADH levels. Urine-specific gravity is going to be low again. We're going to have a high serum osmolality, hyperosmotic volume contraction, but the water deprivation test, you're not going to see a change in the urine osmolality after administration of desmopressin. And the treatment here is, again, hydration. Hydrochlorothiazide, curiously, what this does is it creates a mild hypovolemia, and that encourages the kidney to pick up more sodium, and that's going to increase more water retention in the proximal tubule. So you kind of trick the kidney into increasing water absorption in the proximal tubule, even though you're losing a lot of water in the collecting ducts. So that's a potential treatment there. Same with indomethacin. And then Amiloride is used specifically for lithium-induced NDI. Just quickly, dipsogenic DI, that's a defect or damage to the thirst mechanism. And here we're going to have, hyponatremia is not going to trigger the ADH secretion and thirst. The main treatment is going to be fluid restriction. And finally, gestational DI, that's going to usually resolve after pregnancy, but there desmopressin might be used as a temporary replacement therapy. So really we need to be most familiar with the central and the nephrogenic DI. Okay, that wraps it up for pituitary disorders, both of the anterior and posterior.